Central Nervous System Pathology section of the USMLE Step 1 Pathology Review. Cerebral edema. Cerebral edema is defined as edema of the brain parenchyma. The big deal with cerebral edema is that you can have subsequent herniation of the brain, that is, displacement of the brain parenchyma beyond the rigid partitions in the brain. Obviously, the skull is a rigid container, and if there is something within the skull that ought not to be there, it will push on the normal components, including brain, CSF, and blood, and perhaps lead to compression of important brain structures within the skull. Let's talk about some of the different kinds of herniation that occur with cerebral edema. The first kind is subfalcine herniation, where the cingulate gyrus is displaced beneath the falx, which is the meninges in the middle of the brain, separating the two hemispheres. The cingulate gyrus gets displaced to the opposite side, leading to compression of the anterior cerebral artery. This can lead to infarction and a secondary stroke. Transtentorial herniation involves the uncus, or the mesial temporal lobe. Here, the medial aspect, or the middle part of the temporal lobe, is compressed against the tentorium cerebelli. This is the meninges that separate the cerebellum from the cerebral hemispheres. Here you can have compression of the third cranial nerve, leading to a fixed and dilated pupil. Finally, there is tonsillar herniation. This is perhaps the most severe of all herniations and can be due to displacement of the cerebellar tonsils through the foramen magnum. You can have compression of the medulla, leading to respiratory demise. Here is a diagram demonstrating the different kinds of herniation. Number 1 shows you subfalcine herniation. Number 2 shows you a transtentorial or uncal herniation. Number 3 and 4 really are demonstrating the tonsillar herniation of the cerebellar tonsils down the foramen magnum. Here is an example on gross pathology of subfalcine herniation. Again, you can see the corpus callosum is stretched in the middle, and there is the shifting of the cingulate gyrus on the right going towards the left. Interestingly, you can also see that there is an arrow, a blue arrow, pointing to a large infarct on that side. That was the etiology of the edema. Here's an example of uncal herniation. Here you can see that the temporal lobe is compressing against the midbrain. Now, cerebral edema can lead to hydrocephalus. Hydrocephalus is dilation of the ventricular system with increased cerebrospinal fluid volume. And there's hydrocephalus ex vacuo, which is brain atrophy resulting in the enlarged ventricular spaces. Developmental diseases, neural tube defects. This is failure of the neural tube to close. It is the most common developmental central nervous system abnormality. The first type of neural tube defect is anencephaly. Here there is malformation of the anterior end of the neural tube resulting in absence of the brain, and it is incompatible with life. It occurs in 1 to 5 in 1,000 live births. Another type of neural tube defect is the encephalocele. Here, the diverticulum of the malformed neural tissue extending through a defect in the cranium is exposed, and it most often occurs in the occipital region. Here is a picture showing an infant who has an encephalocele. As you can see, in this case, the encephalocele is larger than the infant's head. Spina bifida. This is probably the most common neural tube defect. It is asymptomatic bony defect or severe malformation of spinal cord manifested by overlying meningeal outpouching in the back. A myelomeningocele is an extension of neural tissue through the defect in the vertebral column, causing cystic outpouching of the meninges, the spinal cord, and the spinal roots. A meningocele is only the meninges poking out of the defect, whereas a myelocele is a defective bony arch with complete exposure of the spinal cord. Neural tube defects such as spina bifida typically lead to paraplegia and urinary incontinence. Folate deficiency in the mother is a known risk factor. Cerebral palsy is a non-progressive, static neurological motor deficit. It is frequently seen in premature babies. Intraparenchymal hemorrhage is also seen at increase in premature babies. There is something called periventricular leukomalacia. Here you have infarcts in the watershed areas of the brain. These are the periventricular white matter areas surrounding the ventricles. It is also seen at increased rates in premature babies. Parenchymal injuries. A concussion is simply a clinical syndrome of altered mental status secondary to head injury. A loss of consciousness, temporary respiratory arrest, and loss of reflexes is usually seen. There is also amnesia of the episode. Another form of parenchymal injury is the contusion. Here you would have direct parenchymal injury to the brain, and there are two forms of injury, coup injury or contra-coup injury. A coup injury is cerebral injury at the point of contact, whereas a contra-coup injury is damage to the brain surface opposite to the point of impact. So you can imagine a motor vehicle accident where there's a head-on collision and the patient's head strikes the dashboard. You will have a coup injury in the frontal lobe, but you will also see a contra-coup injury in the occipital lobe, leading to both symptoms involving the frontal lobe as well as the occipital lobe. Let's talk about some trauma. Traumatic vascular injury. There are three common types of traumatic vascular injuries: epidural, subdural, and intraparenchymal hemorrhages. An epidural hematoma is usually due to trauma directly to the skull, leading to epidural artery tear, usually the middle meningeal artery tears. There is usually a lucid interval before loss of consciousness, and the patient kind of talks for a while and then slips away. Subdural hematoma is tearing of bridging veins. Risk factor for that is brain atrophy and coagulopathy, such as being an alcoholic or being on Coumadin and allowing the blood thinning mechanism to be severe. This can present within 48 hours after an injury. Now, an epidural hematoma is demonstrated here on CAT scan. Not all is lost if you see this on a CAT scan. You may still be in the lucid interval. The idea is to immediately call neurosurgery to remove the blood clot and to stop the bleeding. A subdural hematoma is demonstrated here on an MRI. You can see that the shape of the bleed is slightly different. It is more of a crescent shape as opposed to the lens shape of the epidural hematoma. The crescent shape minimally displaces the brain, and that is why you may have a subacute or chronic presentation of subdural hematomas. Again, remember, epidural hematoma, young person, accident, lucid interval; subdural hematoma, older person, maybe on a blood thinner, and subacute or chronic presentation. Another form of traumatic vascular injury includes subarachnoid hemorrhage. This is frequently caused by rupture of a berry aneurysm. Berry aneurysm is the most common type of intracranial aneurysm, and it most often occurs in the anterior circulation. We often see berry aneurysm in patients with polycystic kidney disease. We're not sure why, but they seem to share the same common genetic mechanism. Clinical features of aneurysms include rupture, usually frequently in the 5th decade, and a clinical syndrome of thunderclap headache or the patient saying this is the worst headache of my life. Again, neurosurgery should be consulted immediately in any suspected case of subarachnoid hemorrhage. Trauma. Outside of the brain, the spinal cord can also undergo trauma. The associated symptoms come about from displacement of the spinal column. Depending on the level of injury, you could have paraplegia if there's damage in the thoracic segment, quadriplegia if there's damage in the cervical segment, and if there is C4 level, cervical 4 level injury, you may have respiratory compromise. This is the end of the trauma section of the pathology review.